Hello, my name is Dr. Stephen Symes. I'm an associate professor of medicine at Miller School of Medicine, University of Miami. And it's a real pleasure to be with you today for a recording of this piano slam program. Today, I'm going to talk to you all a little bit about HIV and AIDS in our community. Before I jump into our topic for today, I've just introduced myself a little bit more. So I grew up in Jamaica, went to school after high school, went to college at Howard University in Washington, D.C., and did medical school there. And after I finished, I came down to Miami, where I studied internal medicine. And for those of you who don't know, internal medicine is really being a doctor for adults, just like a pediatrician would be a doctor for kids. I'm a doctor for adults, and I'm a general doctor. But I also, during my training at Jackson Memorial Hospital, specialized in taking care of patients with HIV and AIDS. I've been a teacher educator at University of Miami, teaching other students, residents, and faculty members. And I'm now what we would call an associate professor of medicine. In addition to my work in HIV and AIDS, I also spend 2 half days a week at a community-based center in North Miami called the Center for Haitian Studies, where we take care of patients who have no insurance and no other means for seeking medical care. So that's a little background on me. And I wanted to take this opportunity to talk a little bit about one of the areas that I'm really passionate about, which is taking care of patients who are HIV positive and who have AIDS. So at this point, I'm going to share my screen, show you some slides that illustrate some of the basic principles that I really wanted to talk about and illustrate. So here we go. Hopefully you guys can all see my slides. I'll start from the beginning. And really, again, it's a pleasure to be with you here at the Piano Slam course, which I think is a great, great program. And I hope at the end will engender some good discussion about some of the aspects that I'm going to talk about. So this first slide talks about the lifetime risk of HIV diagnosis by state. And what it really illustrates is that the darker blue states have a much higher risk for the individuals living there of contracting HIV. Lighter blue, much less or lower risk. And so you can see, for instance, like states in the Midwest, upper Midwest, not much of a risk of contracting HIV, but in the South, very, very high risks in places like Florida, Texas, Louisiana, and actually Florida, we have one of the highest risks in the nation of having HIV. And we're going to talk a little bit more about why that is and what that means and the types of things that we need to do and focus on because of that. So what is HIV? How is it spread? HIV is the human immunodeficiency virus. It causes a progressive destruction of the immune system, which eventually leads to AIDS, which is the disease. And the disease is called acquired immunodeficiency syndrome. Now, what HIV does, it gets into and destroys parts of our immune systems called the T lymphocytes. HIV is spread by sexual contact, perinatal transmission, and also injecting use or sharing blood products like blood transfusions used to be a way in which HIV was transmitted. And again, we hear a lot and you've seen a lot about different types of viruses. You've heard, for instance, about COVID that's transmitted by speaking, coughing, sneezing. That's not how HIV is contracted. It's really spread by direct contact, so through sex, and also sharing blood or blood products. So different viruses have different mechanisms by which they're spread. And again, here's what we're talking about. This virus is the human immunodeficiency virus. And eventually over time, as it wears down the immune system in someone who contracts this virus, they can develop what we call acquired immunodeficiency syndrome, which is the disease. And we'll see what that means. But I want to illustrate again what we talked about before, which is you can see in this pictorial, all these little red dots are HIV virions, which are attacking a T cell, binding to it, and then taking over these T cells, which are a critical part of our immune system, and turning them into virus-producing factories. And then in this lower picture, you can see again that this T cell now is producing more and more of these little viruses that are budding off and then going on to infect additional T cells. And as it does that, our T cells die, they're destroyed, and so our immune system gets weaker and weaker as time goes on. Where did HIV come from? So unlike sometimes you hear about it's not a scourge from God, it's not a punishment for a particular type of behavior or anything like that. HIV, like many viruses, made a jump from nature to man. And we think that jump happened somewhere in the 1920s or so, and has evolved as time goes on. So HIV 1 and 2 crossed from actually non-human primates, so chimps, monkeys, and what you can see in this picture is a hunter in mid-Saharan Africa, in the Congo area, hunting and capturing chimps, right? These non-human primates. And in that process, the hunters got bites, scratches, and the virus that lived within this particular chimpanzee, called the simian immunodeficiency virus, with those bites and scratches, eventually made a jump and turned into human immunodeficiency virus by mutating. And we know this from samples that were collected back in the 1950s, but we also know that this process started a lot earlier, maybe back in the 1920s, and it spread worldwide with global international travel. Now, how can you tell if you have HIV? So we do it by a specific test called an HIV antibody test. Now, when HIV attacks, the body tries to fight back by making these antibodies, proteins that identify these intruder organisms, and it binds to the virus, tells the T cell to fight it. So everyone exposed to HIV makes an antibody just for HIV. These antibodies are very specific. And so we can do a test somewhere between 2 to 6 weeks after you're exposed to see whether or not you have the antibodies in your system. So the HIV test doesn't look for the virus itself, it looks for antibodies against the virus. And it's a great way, again, for us to know what our status is. And I encourage everyone to know what their HIV status is. Now, how can you tell if you have AIDS, right? Can you tell by just looking at someone, which a lot of people, will say, oh, I think that person is so, thin or wasted or so on. And the message, again, you can, looking at these different pictures, who has AIDS, actually no one in any of these pictures has AIDS. In the bottom left is Magic Johnson, who is HIV positive, but he doesn't have AIDS. He's never gotten so sick or so ill. He's always managed to take medicines to control the virus. His immune system has stayed strong, so he's never had what we call AIDS. The girl here with the vulture behind her, that's a young girl facing starvation in the Sudan. The middle picture here is a cancer treatment patient. And in the bottom right here is a patient who has tuberculosis, but is not HIV positive. So how do you catch HIV? I'm gonna emphasize that a little bit more. So it's really through fluids, direct contact. It's not through respiratory, coughing, secretions. And HIV can be spread by blood. So if you share needles, for instance, individuals who are injecting drug users, it can be spread through breast milk from an infected HIV mother to her child. And of course, through sex, through vaginal fluid, or through semen. It's another mechanism that HIV can be spread. And probably the most important mechanism worldwide that HIV is spread is through sexual transmission. And the risk itself with just one sexual contact is not that high unless, again, individuals also have sexually transmitted diseases. So here's a picture of someone who has what we call an STD on the penis, where again, there's a breakdown or erosion of the skin. And you can imagine if this individual is having sex with this particular STD, then there's going to be cells infected with HIV that can cross from him to his sexual partner quite easily, because again, the skin surface that provides a barrier is broken down. That's one of the reasons that barrier contraception, like condoms, actually works well to prevent the spread of HIV. And of course, there are other things like how far along you are in the cycle for HIV, the disease stage that can affect whether or not you're going to transmit the virus. If you're on medicines, you can't actually transmit the virus. The medicines work well to push your virus down. If you're circumcised, you're much less likely to transmit HIV. And if you're going through your menstrual cycle when you're having sex, then you're actually much more likely to contract HIV. If you're using drugs or alcohol when you're having sex, a lot of times, again, there is what we call disinhibition or rougher sex, and that also can increase the risk of transmission of HIV. HIV can also be spread by sharing blood products. And in the past, before the blood supply was well tested, we had individuals who got blood transfusions or hemophiliacs who got blood products before 1985, when we had a test for the virus. That was a mechanism. But since 1985, transfusions or hemophilia is no longer a mechanism by which you can contract HIV. Sharing needles, though, if you're injecting drugs, heroin or cocaine, that has been related to transmitting HIV from an infected person to a non-infected person. And of course, there's also very rare causes like artificial insemination, organ transplant, and healthcare workers. But again, these causes are very, very rare. So I think this is a nice also pictorial that talks about, again, this different idea about how risky it is to transmit HIV. If we took 10,000 individuals, for instance, who were infected with HIV, and we transfuse their blood to someone who is non-infected, then 9,000 times out of that 10,000, and this is before, again, we had a test for the blood supply, you would transmit HIV. Very, very, very common. And you can imagine why that is. You're getting a big load of infected blood and cells, right? High risk of transmission. But look at the risk of just having one unprotected sexual contact through sort of what we call heterosexual penile to vaginal intercourse, right? 5 out of every 10,000 exposures. Now that risk can go up more if, for instance, like we said, you have a STD, or if you have more risky forms of sex, like receptive anal intercourse, right? That's actually much more risky, 50 times out of 10,000. And less risky would be like oral intercourse, 1 time out of 10,000. Why is this important? It's important because a lot of times we can counsel our patients about risk taking and risk behavior in terms of engaging in sex, and that's a mechanism for them to be able to manage risk if they are having sexual contact. What happens when you contract HIV? Like many viruses, what happens is that you go through this initial flu-like syndrome where you feel feverish, you have chills, you have muscle aches and pains, but then about 2 weeks later to 4 weeks later, your antibodies kick in and they start to try and control HIV. And so patients will recover and then they won't have any symptoms for several years, but in the background, their immune systems are slowly being worn down and depleted. And in that process, while they're not feeling well and they don't look sick, they're spreading the virus to others if they're not on treatment. So you have progressive destruction of the immune system, unusual infections, Here you can see someone, again, who has an unusual infection, tumor in the oral cavity called Kaposi's sarcoma involving the gums, right? Very unusual, used to only be seen in Middle Eastern individuals, later stages of life, but we started to see this very rare form of cancer in younger individuals in the 80s and 90s because their immune system was so weak that these cancers started to express themselves. And again, if you don't get treatment, you'll get sick and eventually you can die as you get these different types of rare infections. There is one individual who developed an infection in the lungs. You can see something abnormal up here in the right upper area of the lungs, which is pulmonary tuberculosis. And tuberculosis was disappearing in the world before, again, the 1970s, 80s, when HIV allowed it to make a comeback. Here is a patient who has what we call itchy bumpy disease, again, in the skin. If you and I get an injury to our skin, like a mosquito bite or something like that, we get a little bump, but that inflammatory response decreases after a couple of days. Our immune system knows how to regulate itself. In HIV patients, these itchy bumps don't go away. They stick around, they persist because the immune system is not functioning in a structured and adaptive way. There is another patient who has a rare type of illness involving the skin face called molluscum. Molluscum is very, very common early in life in young kids, but then as our immune systems develop and get stronger, it kind of goes away. We never see it in adults or even young adults and adolescents. But if you're HIV positive, you know, it can come back and express itself because the immune system can't contain it. There's another patient here you can see in the upper aspect of the face, something called what we call shingles. Older people can get shingles. Again, it's because their immune systems are getting weaker, nothing to do with HIV. But when we see shingles in a younger person, here involving the face, on the right side here, an individual on the chest wall, then we suspect there may be something else going on that's damaging their immune system and allowing this chickenpox virus to be expressed and come out of the body. Same thing with oral thrush. We see oral thrush in young kids. Doesn't, mean much of anything in young kids. Eventually will go away as their immune system gets older. But when we see that in an adult, it usually means that there's something wrong with the immune system and the immune system is getting a bit weaker. So what makes a difference? Well, one thing that made a huge difference in the mid-90s was medications that we call antiretroviral, directed against the virus. And back in the 1980s, 1990s, when I was first treating patients with HIV, they would have to take these cocktails of up to 18 tablets a day. They worked, but they were really hard to take, lots of side effects. You'd have to take them on a strict schedule. Well, things have evolved so much that now we have medications that you can take just one tablet a day, combination meds. There's 3 meds in this one tablet that shuts down the virus and allows the immune system to recover and recuperate. And we also, besides these single pill combo meds that work really well, we also have an injectable that you can take every 2 months that controls and contains the virus and allows you, even if you're HIV infected, to live a completely normal life. So it's really, really a huge progress that's happened over time. Now, what about who catches HIV? Remember that first slide I showed you? In our community here in Florida, we're one of the hot spots in the nation, the whole South, but even more so Miami, Fort Lauderdale area. And when we look even within that, even in the South, that we look at distributions or breakdown based on race, right? HIV excessively affects persons of color, Blacks, African Americans, Hispanics, Latinos, compared to the majority population. So Here in the South, for instance, over 50% of all new HIV infections are seen in African American or Black men or women. And it's very similar actually in the rest of the United States. So why is that? And another sort of individual, another group of individuals who, again, have an excess risk for HIV is transgender individuals and LGBTQ individuals, where the risk of contracting HIV is 3 to 9 times higher than the general population. Now, for you guys, whenever you see things like this, whenever you hear about, well, in a particular race or in a particular minority group, there is more of this particular disease, it's really, really important to ask a few more questions. Because if you don't, what ends up happening is a lot of stigma associated with race or with sexual identity. And so, one of the questions that always comes up is race a root cause for contracting HIV? And what I really want to emphasize for you, and what I hope you all take away and discuss some more after this lecture, is to realize that race, ethnicity is a substitute indicator for factors that tend to increase HIV and AIDS cases, right? So, individuals, again, there's nothing genetic about contracting HIV related to race, but there are factors that put you at a disadvantage, just like we've seen with the COVID pandemic, that allow the disease to spread more easily in a particular population, individuals have less access to care, less resources, and therefore be overrepresented in a particular disease. And I want you guys to spend a few minutes just talking about what you know about how this operates and what you think, again, might lead to this increased risk based on race or based on gender identity. So again, to emphasize, race is not a root cause for HIV and AIDS, and that's really important. Just like it's not a root cause for COVID or diabetes or kidney disease or anything like that. What works? So one of the messages I really want to tell you is that culturally appropriate providers and centers, like this one that I work at, the Center for Haitian Studies, really helps to break down barriers and allow people to get high quality care in a manner that they find acceptable, that embraces them, recognizes them for their differences, and allows them to have control over their own health. Having community health workers that go out into the community and not just depending individuals to come into a major medical center is something else that works. And also for people who are positive, getting their partners on something called PrEP, where they can take a single tablet every day to prevent acquiring HIV, also works really, really well to prevent you from contracting HIV. Here is a slide that shows one of our programs that we run at University of Miami called CHAMPS, which is a community health worker program that operates in Liberty City, where again, we have individuals who are respected in their community, who get out and do education, messaging, and allow individuals better access to care and help to navigate the healthcare system. And it makes all the difference in the world in achieving the best outcomes for patients. So here's a slide that I always love to show. And it shows on the left-hand side an individual in March of 2003 who has HIV and tuberculosis, both. And he's sitting on this bed here with his mother. And you can see again, he really looks like he's in trouble, right? Very wasted, has lost a lot of weight, doesn't look well. And you can see just 6 months later, that same individual, the remarkable transformation, really remarkable, with treatment for both his HIV and tuberculosis. In as soon as a few weeks, we start to notice this difference. And as quickly as 6 months, you can see again that transformation in the health and well-being of that individual here with his daughter. And so even in some of the poorest parts of the world, right? This was an individual in the central plateau of Haiti where they don't have a lot of hospitals, don't have a lot of advanced care, using community health workers to help to deliver medications to patients in their homes, educate them, allow them again to be able to talk about side effects, about barriers to taking meds, make sure they have the appropriate nutrition, made all the difference in the world in achieving fantastic outcomes in terms of health, even in some of the poorest areas of the world. And so to summarize, know your status, get tested, have safe or no or safer sex, right? And we talked a little bit about what sex is more risky and what sex is less risky. Sex on drugs or sex when you're drunk or rough sex is a lot more risky than having sex with a partner that you know, that you trust, and that you can have open and responsible communication with. Having PrEP for your partner, if you are HIV positive, really works to prevent transmission. And knowledge is power. And so I'm going to stop here. And my message for you is to kind of go back to that core question that I asked earlier, which is to talk amongst yourselves a little bit and with your facilitators about thinking about risk factors for HIV and the things that drive those risks, right? Related to what zip code you might live in, and and how that's, and if you have access to care, if you have health insurance, and how all that may impact whether or not you're able to have the best possible care, and how that is then reflected in excess risk, what we call health disparities or inequities in health, related not just to HIV, but also to other things that you've heard about, like COVID and so on. So these are all really important public health initiatives. And I'm going to stop there. Once again, thank you guys for listening to me. Congrats to Piano Slam, and go Canes. Take care.